Hello and welcome back. I hope you had a great lunch break and enjoyed some of the fabulous weather, or maybe not so fabulous. We are happy to have Dr. Van Guren and this cadre of presenters here today from Buncombe County to talk to us about this very important topic and very current topic of leveraging point of care diagnostics to address STI syndemics. So I will start by introducing the speakers in the order that they have on the slide. So Dr. Van Guren, Dr. Olivia Van Guren, also known as Libby by her peers, is an assistant professor in the Division of Infectious Disease at UAB. She completed her combined MD MPH at UAB, followed by internal medicine residency and chief residency at Tulane University. Returning to her home base, UAB, she did her fellowship training and postdoctoral research in health outcomes. And she has a focused interest in providing sexual health care for all, HIV treatment and prevention, STI prevention, STI diagnostics, and vaginal health. Dr. Van Guren teaches learners across all levels and serves as STI prevention faculty for us at the Southeast team. She was also very new, hot off the presses, a recent awardee of the ASTDA Early Career Award, which acknowledges her outstanding work in the field of sexually transmitted disease. We are so happy to have her here today. Her cadre of teammates include the Buncombe team. Molly Cleveland is a public health nurse dedicated to promoting health and wellness throughout working with many members of the population who are vulnerable. She graduated from Western Carolina University and went on to do a lot of great work in patient care, including public health. She has been working with Buncombe County for quite some time with the Health Mobile team and delivers community-based work out there to historically marginalized populations and those in rural communities. Thank you. We also have Sue Hanlon here with us today. She is an experienced nurse who has social work experience as well, and a strong background in public health. She is a master of building teams and promoting advocacy in this area. She draws onto public health because she's really passionate about the work that she does, currently working in public health as a supervisor in Buncombe County. She is working with the mobile unit and delivers community-based care to historically marginalized populations, including rural communities. And then finally, but definitely not least, we have Carrie Sanders, who is a multifaceted, trauma-informed nursing professional with over a decade of experience working in urban, rural, and international settings. She is passionate about advancing health to all the people that she works with, and does it with compassion and with a holistic approach. She currently serves as the public health nurse on the Buncombe County Public Health Mobile team, and again, works with the same population as our other Buncombe County team members. Thank you so much for joining us here today, and I am very much looking forward to your presentation. Turning it over to you all.
Thank you. So I'll get us started. We're going to actually switch slide decks halfway in between. I'm going to start and then I'll switch it over to the Buncombe team. So like Candace said, I'm Libby Van Guren and I'm at UAB. So I'm going to start. These are my disclosures. I do a little research. I do a little consulting. None of it's really very relevant to what we're going to talk about today, but you can see here the companies and funders that I've worked with. So today we are going to do a few different things. My role is going to be to introduce you all to the current landscape of point of care STI and HIV diagnostics in terms of what's out there, what's available, and how we can use those things. I'm also going to talk a little bit about some of the new innovations in remote / at-home collection and testing options. And then after we go through what is available and what the landscape is, I'll pass the mic to the Buncombe team, and they're going to talk about their experience operationalizing these sorts of tools to create a testing program that reaches people where they are using a mobile testing van. So for me, I'll get started. I have begun my presentation with a table that I made that has, a quick and dirty reference for all the different tests that are available right now. So more for y'all to have as a reference when you have these slides after you leave this training and can't remember what we said, but want to know what's available. If you can't find it in your notes, I have a nice summary here for you. So I will go through this very briefly, and then I'm going to talk a little bit about point of care testing in general. But I'm going to talk today about HIV point of care testing, hepatitis C point of care testing, gonorrhea, chlamydia, trichomonas, and syphilis testing. So actually what I think I might do is go ahead and move on to my next slide, and then I can come back and we can look at these again as a summary. But the take-home point of seeing this table is that we do have several options that are available at the point of care, which is quite excellent, given that when I was earlier in my training, back when I was a fellow, we really didn't have a lot of these options. So the landscape of STI and HIV testing out in the community and in the world where the patients are, I think has expanded greatly in the last 10, 15 years. So I just want to talk a little bit about what point of care testing means. So this is an acronym that comes from, they've talked about it in several different papers, but this image is from a paper in 2024 talking about the criteria we use to assess if a point of care test is a good point of care test. So point of care means that you can do the testing at the bedside or in the same visit that a patient is seeing you. So usually these are going to be tests that can be done in a short turnaround time. So they can be done with, between a couple of minutes to about 30 to 45 minutes is typically where we kind of draw the line if something is point of care versus a rapid turnaround test. So as you can imagine, these tests can be really useful in resource limited settings. They're also very patient centered. But as you can also imagine, some of these tests are not, if they're performed at the bedside, may not have performance characteristics that are as rigorous, or we might worry that they might not, than tests that go to a central lab to be run. So this assured criteria was developed to help people who are developing these tests in the diagnostics industry to determine whether or not a test is both able to be performed quickly, but also high enough quality to be safe and recommended for our patients. So we want these tests to be affordable. Obviously, tests are no good if people can't access them. We want these tests to be sensitive. So if someone's coming into the office and they want to answer right now, and we get a negative result on this test, we want to be sure about that negative test result. So few false negatives is really important if we're treating people at the point of care. This is especially true in STI care settings, I think, where we have patients, as you all probably know, who come and we may not see them again if they leave our office after that one visit. I think an example of a point of care test that I'm not going to talk about today, but that many of you are probably familiar with, is wet mount microscopy, which we often use to look for trichomoniasis. It is a test that can be performed at the point of care. We collect a swab, and within 10 minutes, we put the microscope on and we look underneath and look for the trichomonads swimming around. So the second S is specific. That test is quite specific, but it's often not very sensitive. So we may miss cases in the setting of that test. Sometimes it's the best that we have, but it is an example of a test that maybe is not perfectly sensitive. We also want these tests to be specific. So we want to know what we're seeing when we get a positive result. We want to know how to interpret that and know that it's a true positive. User-friendly, we're going to talk a lot about this as we go through the slide. We want these tests to be able to be used not only by the clinicians who are seeing these patients. One of the things I do in my practice is I work in a vaginitis clinic. So I read microscopy, for example. Being able to perform microscopy is you have to get a trained eye to do that. Some of these tests we're going to talk about today are quite simple to use in settings where maybe a physician or a nurse practitioner or physician's assistant is not who's performing the testing, but perhaps even a community member is able to use it. So being able to disseminate these technologies to the community, I think, is really important. Rapid and robust, of course, we want these tests to be fast, as we mentioned. Equipment is something we'll talk about as well. So having the ability to not have a big bulky platform that takes up space in your clinic space or in your mobile van can be really useful. So a lot of these point of care tests that we are going to talk about today are either single use and can be used on a tabletop very small surface area and then discarded. Some of them also have area, like small surface area, but can fit on a tabletop and don't take up a lot of space, but can be used in batching as well. So equipment free, I think, is an ideal for a point of care test as well. And then deliverable. Things that are accessible are really important. Again, as I mentioned, affordable and deliverable kind of go together. We can't utilize these technologies for the people who need them most if they're not able to be accessed. So that was just a quick, brief description of what we are going to be talking about today in terms of tests and the kind of characteristics we want to see in these tests. All the tests I'm going to talk about today are also CLIA waived, which kind of goes to that accessibility piece. That means that they are they have an FDA exemption to some of the regulatory processes that are needed to have a lab test. They are low complexity and they're easier to interpret than maybe some others. So that makes them easier to implement into non-traditional settings as well. And then as we talk through some of these tests, many of them are able to be used in the setting of self-collection. So in a place where a patient collects their own specimen and then puts it on the test with the assistance of a provider. And at the end, I'll talk a little bit about some things that not so much are point of care, but are done in the home. So that is just a quick summary of what point of care testing means. And now I'll go into some of the options that we have out in the world. So point of care HIV and hepatitis C testing has been available for quite a while compared to other things. I think this was one of the first point of care tests that we had available. Some of you may be familiar with some of these options. We have the OraQuick test, the STI test, and the Abbott finger stick test that is looking for the antigen and the antibodies. So a few little details about these two tests, or these three tests. OraQuick is one that utilizes an oral specimen. So you take the test and you use oral secretions, a cheek swab, to test for HIV antibodies. That will be positive, as you can see, with 2 lines, or negative with only 1 line for the HSV or the HIV-1 antibody. And it's a similar platform for the hepatitis C testing as well. And then as far as the INSTI, that's a similar test, but it is using a blood specimen. So you do a finger stick and then it will give you a result based on the antibody presence as well. And then finally, finger stick as well is our HIV P24 antigen antibody test. Again, you put the blood specimen onto the little sample pad and it will give you a positive result for the antigen and the antibody, and that would indicate a positive test. I saw a question in the chat about controls. So that's a great question. Most of the time when you buy these tests, they will come with instructions on how to do a quality control assessment of your batch of tests, and you do that regularly with these tests. So it's an internal process that is provided by the testing company. All of these tests result in less than 30 minutes. They're all summarized on the chart that I showed you earlier. We can go back to that real quick. The OraQuick usually comes back in about 20 minutes. The INSTI comes back in a minute or so, so it's extremely rapid. And then the Determine, which is the one that tests for the antigen and the antibody, comes back in about 20 minutes. So going forward on my slides, I do want to talk a little bit about some important pieces of the antigen antibody distinction. Many of you have probably seen this chart before. I certainly have as an infectious diseases doctor. We have these generations of HIV tests, and it's really important to know what test you have when you're using these tests out in the community, because some of them may miss acute HIV infection. So in the setting of an antibody-only test, which is going to be the first 2 tests I talked about. This is actually a slide from the Determine company, so they made this test, or this slide about their test. But the earlier generation tests, which look for antibody only, are going to be ones that you may have cases that were infected, a couple weeks ago that you may miss. So it's really important to know what test you have. If you have a 3rd generation antibody test, 2nd generation antibody test, you can have a negative result in a person who's actually infected, starting at 21 days after infection. So the 4th generation test, which has the antigen positivity, becomes positive much quicker. So that is something to keep in mind. And again, if you are seeing people in the community and you're concerned about acute HIV, having a good, robust screening script about that is really important. So when you're doing the testing, asking questions about, lymphadenopathy, sore throat, rash, headache, all of those things, to make sure that you don't miss the opportunity to get a viral load test or have someone see someone in a more traditional clinical setting. So that is an important point when we're talking about these tests. I'm going to move on now to talk about a few of the options for bacterial STI testing. I see there are some questions coming in the chat. I'm actually going to save those questions until the end so that I can get through my content so we have enough time. So please put your questions in the chat and I'll answer them when I get through my section of the slides. This is a really exciting test. It's a handheld test that looks for 3 different bacterial STI organisms. So this is a sexual health Visby medical test. It's a PCR test and 1 single-use instrument. So multiplex PCR looking for gonorrhea, chlamydia, and trichomoniasis. You use it on vaginal specimens. Last I looked, that was the specimen type that it's approved for, but I know that this company is probably looking to get other specimens validated. I'm not sure if anybody has updates on newer things we can use this for, but right now, vaginal specimens are certainly something that can be used for this. And the results come back in 30 minutes and then you throw the test away. Going back to our assured criteria, as you can see, it's pretty easy to read. You have the 3 names of the infections here. Once the test is run, you get this check mark. And if anything comes back purple next to the designated test, that's a positive result. Quite specific and quite sensitive as well. Another option for point-of-care gonorrhea and chlamydia testing is not a handheld test. This is one of the ones I mentioned that is a tabletop platform. So this machine is about the size, I'm looking at it now, it's about the size of my, my phone on my desk. It's not very big, but you can do PCR in this as well. And you can do multiple specimens over and over again in it. And this can detect male urine and female vaginal specimens, also female urine for gonorrhea and chlamydia. Again, the results come back in about less than 30 minutes, and it can be really useful in settings that have a little bit of space on the countertop and have higher volumes. I will say, going back to the Visby test, these can be quite expensive. So I know that many clinics are using them, but cost is sometimes a limiting factor with these single-use handheld tests. Whereas if you buy an instrument, you do have a capital investment that you have to make and then buy the cartridges, but it can make sense for some settings more than others financially. This test is, I call it a not quite point of care test because it takes a little bit longer, but depending on your setting, it could be something that is same visit at least. Cepheiad makes a machine, the Gene Expert machine, which many of you may be familiar with. It's used for a lot of different infections. It's actually used in TB management as well. But this Express machine can fit on a tabletop. It's a little bit bigger than the Binks that we saw earlier. It can hold 4 cartridges, as you can see down here, and run them all simultaneously. It can look for gonorrhea, chlamydia, trichomonas, but it also has a vaginal panel that looks for BV, trichomoniasis, and yeast. That's the middle one here, this Express MVP. So again, it takes about 90 minutes for results to come back with this one. So depending on your clinical setting, it may not quite be something that people can get their results in the same day and see the results during their visit at the point of care. But we're actually working to implement a machine like this into our vaginitis clinic. And the workflow planning has been a little bit challenging, but we're hoping to have the machine, have the patients check in for their appointment, provide a specimen. This is only useful for the vaginitis testing for people who are symptomatic, important caveat. Provide their specimen, have their visit, and then by the time their visit is over, or like right after it's over, we'll have a result for them. So you don't have to wait multiple days at least. So I'll go back to my initial slide. I probably should have inserted these slides throughout, but we have, oh, and I apologize. I saw the question about the OraQuick for hepatitis C. It's not an oral swab. It is a finger stick swab. So the company is called Oraquick, but it is a finger stick swab. So going back to the chlamydia, gonorrhea, and trichomonas testing, as I mentioned, all of the ones that I talked about that are point of care take about 30 minutes, and they are all CLIA waived as well, and they're all working with nucleic acid amplification technology. So this, going back to our table, is, the different specimens that we can use as well as the organisms detected. So finally, I'll talk a little bit about HIV and syphilis combined testing. I think the folks from Buncombe are also going to talk about this. The combined syphilis HIV point of care testing, many of you may be familiar with. Again, it's a little cartridge that is a single use item. You'll have patients provide a blood specimen through a finger stick, and it goes into the little hole here where the sample goes, and you place a buffer in here. Looks familiar to COVID tests also, with a respiratory swab for that one, but a blood test for this one. And then, as you can see here on the panel to the right, you can get a reactive syphilis, a reactive HIV, or a reactive both compared to this control here. This is from the company that makes this ChemBio test. It's also CLIA waived, and it shows results within 10 minutes after after you put the buffer on. So it's a nice option if you're trying to screen people for multiple things. There are also syphilis testing options that do just the syphilis point of care. Again, these are treponemal antibody detection. We're going to talk about that in just a minute. From a finger stick sample, it's similar to the previous one. Health Check makes one. But I do want to talk about these tests specifically because it is a challenge, I think, in some settings to find how these are useful. So I've got a little bit of a case, and I'll just talk through it. I'm not going to ask for audience participation because there are like 1,000 of you, but you have a 45-year-old man who presents to clinic. He took this test at home, actually, which we'll talk about in a minute, a syphilis test, and he gets the following result. So you have the control, and then you have the treponemal antibody lighting up positive. He tells you he had syphilis that was treated about 5 years ago. So put a pin in that one. We're going to go to this next one. Another 45-year-old man is doing one of these tests, and he had an at-home test that was negative, but he reports that he had sex with a new partner without a condom 1 week ago and noticed a painless sore on his penis yesterday, which led him to take the test. So these are two scenarios that I think we need to be mindful of when we're implementing these syphilis tests that look for treponemal antibodies, because the treponemal antibody test is the way that we perform these at-home tests right now. As many of you may know, syphilis diagnostics are, challenging at best because they don't look for the specific organism. They look for a treponemal antibody response, or they look for a non-treponemal like an RPR is a non-treponemal test that will be reactive in the setting of syphilis, but it's not specific. So like I mentioned, there are some, and I'll come back to those cases in just a minute, but this technology that we talked about with the point of care syphilis testing is now approved to be done at home in some settings. This is an example of the First to Know test, which again, you provide a blood sample and it gives you this control versus positive result here. It gives you results in 15 minutes. Everything is done in the home. So this is self-collect and patient interpreted. I think this opens up a box that we need to be aware of because people will come to us. I think it's a game changer because it will help us detect new cases, but it's also going to become positive in people who've been infected with syphilis and treated before. So these are the instructions that come with that test. It's an at-home over-the-counter syphilis testing kit that's a lateral flow device like COVID test. It's qualitative, so it's going to be positive or negative, and it detects the positivity of a treponema palliative antibody. So what we would see here is a positive result means a new infection or a history of infection. Now, I think that the company did a pretty good job of creating instructions for patients about what to do. This is the patient-facing instructions. I'm sorry, the picture kind of cuts off, but if you go to their website, you can see it. They say, a positive result means that you either have syphilis now or you had syphilis before. See your provider. The negative test says it did not detect antibodies. See your provider if you're still having symptoms. It is possible you tested too early. So they're trying to give patients good instructions, but I think we as providers need to be ready to help interpret these results for our patients because and then they give on their website actually what to do if you test positive. Another good thing they do is give instructions for patients on how to find a health department to receive treatment. But we're going back to our cases. So a few things here. The first patient that we had who had a history of syphilis. As we mentioned, it's a treponemal antibody test, so it's always going to be positive. It's a qualitative assay. It's like a urine pregnancy test. Any line should be read as positive. So the patient probably shouldn't have used this test in the first place because he's always going to be positive. So it's good to, when patients come to you with these results from home, perhaps understand the context of why they took the test, and that will help you provide your assessment. So in these settings, I would always contact the local health department to try and get some collateral information to help support your patient. You know, if they are a new contact to syphilis, for example, and they're worried about a new infection, or if they have a primary or secondary syphilis symptom, that may be different than someone who just took it for screening purposes and was positive and had no reason to take it. The next case is my final slide, and we talked about this as well. So this is a situation where the patient took the test too soon, probably. So they had a negative, but the clinical syndrome here is for primary syphilis. It's a definitively negative test, but that's because so early in the disease course, they may not have developed any symptoms, or they've developed symptoms, they haven't developed any antibodies. So in this case, you would definitely still consider treating them. I think I worry a little bit about people taking tests in these scenarios and then us missing the opportunity to treat them with symptoms. So my call, I guess, would be to ensure that the messaging around at-home tests are appropriate for the right clinical scenarios and not so much for symptomatic patients, because antibody formation for syphilis can take about 12 weeks after the infection, actually. So those are just a few quick updates on what is available. So I want to go back to my initial slides with the table. Again, I have my syphilis testing on here with the details. So all these tests are CLIA waived, and all these tests are things that can be used in a lot of different settings, including one like our colleagues at Buncombe are using. So I'm going to stop sharing and let them share. But while they're pulling their stuff up, I'm going to look in the chat and see if there's any questions that I can answer while they're getting ready. So the first question I see is the OraQuick question, which I already answered. Hepatitis C, I work in a college health clinic. Do you recommend routine hepatitis C screening for 18 to 22-year-olds? So not necessarily. Universal screening for Hep C is something we do in a lot of our emergency departments. Honestly, I don't deal with a ton of Hep C myself, so I would have to make sure I understand exactly when they recommend starting doing universal screening for people, but definitely for behaviors like IV drug use, MSM, I would do it. How accurate are the at-home tests for HIV? The at-home tests are things like the OraQuick, and they are sensitive for the antibody, but again, they're not very specific, or they're not very good at detecting early infection. So you can have false positives and false negatives. So the sensitivity is not wonderful. And I'm gonna pause and I'll go back to questions after the other folks do some presenting. So I will let y'all take it away and we can answer questions together at the end.
Great. Thanks, Libby. Hi, I'm Sue Hanlon, and I am the Public Health Mobile Team Nurse Supervisor, and I will be presenting today with two of my coworkers, Molly Cleveland and Carrie Sanders. Next slide, please.
Okay, and hold on just a moment. Let me get this back to where I want it to be. Okay, let me change the settings. Okay, all right.
Thanks, Molly. We have no disclosures. Okay, and before we get into specifics, Molly and Carrie are going to get a little more into the detail about how we implement our rapid testing. But I wanted to give everyone a little bit of background on who we are. So, like I said, we're the Public Health Mobile Team, meeting our community needs through innovation and collaboration. Our mission is to partner with our community to increase equitable access to public health services, focusing on those historically underserved by the healthcare system, low-income areas, and rural communities. Here we are at our ribbon cutting last year with our new RV. Next slide, please. And this is who we are. We're a lean, mean team of 5. So we have the 3 public health nurses who are presenting today, Carrie, Molly, and myself. We also have one peer who is also an emergency management specialist and an administrative assistant. We've been around since July of 2022, and we have served thousands of Buncombe County residents. We deal with everything from emergency response, infectious disease outbreaks, and community-wide prevention and education. Next slide, please. Okay, why we do what we do. We do this to get public health out to the people who don't come into brick and mortar for services. And that's for a multitude of reasons. We're also housed, we're a consolidated agency. We are Health and Human Services. People may have had an experience with Child Protective Services here. We do have guards who sit in the lobby. People may have transportation issues. The list goes on and on and on. So we're very passionate about public health, all of us, every one of us on this team, and we're passionate about wanting to get public health services out to the historically underserved. And here we have Carrie. We also have a van. We have our RV, and here's Carrie administering a vaccine at an event we went to. Next slide, please. And so this slide here just talks a little bit about what we do on a daily basis. And everything we do starts with collaboration with community partners. I can't stress that enough, how critical that is. You don't just roll on up into a community and be like, we're the health department, we're here, we're gonna, test you. So we've worked very hard to find those community groups, community members who are really tapped in to the populations we're trying to serve. So once we've established that connection, we are able to set up events. We go out about 3 times a week, sometimes more. We can do immunizations, immunization reviews. Our peer is a huge part of what we do, linking people to peer services, linking them back into our syringe services program, harm reduction program. Obviously, rapid testing for HIV, Hep C, and syphilis. We do confirmatory blood draws with that. We also can screen for site-specific chlamydia and gonorrhea, and we can treat on the spot for syphilis for those who meet criteria, and additional lab draws, referring people to community resources, referring them out. I mean, we're talking about we've got a syndemic with STIs, and the folks we're seeing, it's usually there's a lot going on. There's a lot of issues that we're dealing with at one time. Okay, and next, I'm going to hand this off to Molly, who's going to talk to you a little more specifically about our rapid testing we do.
Okay, thanks, Sue. Hopefully everyone can hear me. Okay, so yeah, just to kind of go into a little bit more about our rapid testing. Libby talked about all the different kinds of point of care tests that are out there, and we do 3 specifically. We have the OraQuick HIV and hepatitis C, and then we have the CanBio, which is for HIV and syphilis. So the nice thing is that we only need 1 finger stick to run all 3 tests at the same time. And the results, like she said, are very fast, only 15 to 20 minutes. A reactive result would prompt a confirmatory lab draw, which we can do, which obviously would take a little bit more time. But often, once people have bought into doing the rapid testing, if they have a reactive result, they're more than happy to have the lab draw done and kind of do some further education and treatment. One caveat, is that since we do the OraQuick HIV and the ChemBio, which also tests for HIV, we have something called a dual protocol, which means that if there's a positive for both of those, that would be diagnostic. So normally with these, they're screening tests, but if you do get two positives, that would be diagnostic for HIV. Um, at outreach events, we're always out and about. That's what we do. So we see a better response to rapid testing than if we were going to do serology alone. Often the people that we work with are on the go and they're busy and they didn't even expect sometimes that we were going to be there. And so they don't really want to have a long drawn out appointment, but they're responsive to a 15-minute test. And while the test is running, we have that time to talk with our patients further about their sexual health, educate them. Like Sue said, maybe do some other testing for gonorrhea and chlamydia or other STIs, and then maybe refer them as needed to community partners or back to our health department clinic. But it just creates a nice time to talk and connect with our community. So, there are some pros and cons of these tests. Obviously, a pro is the fast results, really easy to perform. Most people are open to getting that one finger stick. No lab draws, unless there is a positive, and then we would, of course, encourage a lab draw for diagnosis. Um, One of the best things is that we can do same day treatment. So if someone tests positive for syphilis, we are able to give them bicillin or doxycycline, depending on the patient and their status. So once again, it's just one finger stick for all three tests. And the best part for us is that we can perform these tests anywhere. So um, we often go to, like day centers where people who are unhoused are maybe coming to get a hot meal, or maybe an engagement market, people are coming to get free groceries or free produce, and they don't have a lot of time. They're trying to get in and out, but they're able to connect because our testing is so quick. And we try to be really approachable, right? We're nurses in a van, and yeah, like we're meeting people where they're at. And so we often find that people are open to doing testing because we are coming to where they are, we're making it convenient, and we're non-judgmental, and we're trying to remove the stigma from STI testing. There are some cons. These tests are, like I said, except for the dual protocol, they are screening only. So we always reiterate to people that if they were to get a positive, let's say they got a positive on the Hep C, we would want to draw blood for diagnosis because this is just a screening. So these are very accurate tests, but there still is the very rare chance there could be a false positive. So we always tell people, Sue likes to say, don't blow up your life, right? Like don't go change everything because you got a positive on this rapid test. Let's do some further education around safe sex. Let's be careful, but then let's do the blood draw for the diagnosis and treatment if needed. And again, this kind of goes without saying, but we can't perform rapid tests on someone who's had a history of hepatitis C, HIV, or syphilis because it's always going to show a reactive or positive result. So if someone did come up to us and wanted to get tested, we could test for, maybe they said had hepatitis C before, we could test for the other ones rapid, and then we could do a blood draw for hepatitis C, for example, to see if they had an active infection. I think, this has been mentioned multiple times today, just kind of normalizing the language around STI testing and taking the stigma away. But because, especially with syphilis, we've seen it on the rise. And I think syphilis is something that people kind of thought about years ago and are kind of surprised when we tell them that, hey, syphilis is, the rates are really high in our community. I think people are surprised to hear that, but that kind of normalizes why they should get tested. We're not singling them out. We're saying this is just something that's very prevalent. So let's go ahead and get tested and take care of your health. So, just like any healthcare services, we have forms, questions and forms. But, after just a real basic consent form and getting some demographics, we do that quick screening to see, do they have a history of Hep C, HIV, or syphilis? And if not, we can proceed. And then, of course, once the tests are running, we can ask a lot more questions about their sexual history and their sexual health and determine what other tests that we want to run that day or what tests they want to run, not we want to run, they want to. And then, like Libby mentioned, these are really, there's not a lot of equipment, right? Like it's just these little tests that we have. And then with this, we just need lancets, gauze, band-aids, really simple supplies. So we can take these really anywhere. We can find someone who wants to get tested. So you can be creative with these tests, which is one of the best things. So now I want to turn it over to Carrie, and she's going to go into a little more detail about each of these tests.
All right, thank you, Molly. So here's a little flow sheet that is not inclusive of everything, but just to give everyone a general idea of what we're looking at and how we decide to move forward for the rapid tests. So the first thing that we ask is, has the patient ever tested positive for Hep C, HIV, or syphilis? And as has been mentioned, if someone does have a history of one of these or several of these, we can still do a rapid test on the tests that they do not have a history of, and then we can do serology for the other ones. So yeah, in the case of if they did have a history of Hep C, we can draw their labs, test and find out their current infection status. Of course, we would provide education and encourage regular testing, and then do the rapid testing for the other ones. So following the no, we just go ahead and perform the rapid or point of care tests, and then read those results and provide those to the patient. So if those results are negative, there's no further testing required at this point. However, we do really want to provide education and encourage repeat or regular testing. And as Libby mentioned, we really need to be aware of these timeframes. So because we were doing antibody testing, if someone was recently exposed, they could have a negative result even if they do have they do have syphilis or HIV or Hep C. So we want to make sure to provide that education, especially if they are having symptoms. We are not able to perform physical exams out in the field. So in our case, we would make sure to get somebody in with a provider to do further evaluation and see what's going on. If someone does have a positive rapid test, then we do want to draw those confirmatory labs and then treat and or refer appropriately. And I'll go into a little bit more detail what that looks like as we move forward. Next slide, please. Okay, so coming back to syphilis, because we know it's an issue. Rates are on the rise, and congenital syphilis is a really big concern. So by providing rapid syphilis testing, we are able to do a lot of early detection, which can help decrease transmission rates, get treatment out there, and again, help prevent congenital syphilis cases. As Sue mentioned, our community partners are incredibly vital for testing, for treatment, for follow-up. So we really rely on them to be able to get into communities and oftentimes to find people who need to get treated if they were not able to get treated the day that we see them. One quick story is we had a syphilis patient who we actually did not do a rapid test on, but we knew they had syphilis and she was pregnant, and we were not able to get her into the clinic. So our team was able to go and give her bicillin and be able to prevent a possible congenital syphilis case. And these are the things that we really want to focus on. Like this is why we do what we do. And another just like common thing for our group specifically, like we are out in the community, sometimes we're in camps, and we're able to work sometimes with sex workers or people who have substance use issues, and the clinic is a huge barrier. So being able to test people like as they're running from one place to the next is something that we really want to focus on, and that is what's going to really make a dent in the issues that we're dealing with right now. Next slide, please. Okay, so for next steps for syphilis, and I've seen a few questions here, so hopefully this will answer some. So if we do have a reactive result for the syphilis test, which in our case is the ChemBio, we've already asked if they've had a history. We want to ask again. Sometimes people forget, and then we tell them, oh, you actually had this reactive result, and they're like, oh, well, I did get a big shot one time. So we want to confirm their history, ask them about current or recent symptoms and exposure. Before treating, we do want to draw confirmatory labs. So we are going to draw for an RPR and also, and therefore titers. And we're actually have been doing an additional request to also do the treponemal antibodies test in addition, given the reactive rapid test. And as Libby was talking about, there's all these different kinds of tests. So the confirmatory labs may vary. If you are doing a different rapid test that's looking at RPR, then you may want to do the confirmatory looking at the treponemal antibodies. So we're going to draw those and then ideally provide treatment. This is going to vary a little bit depending on who you're dealing with. So the main people that we want to focus on for treatment are those who we are worried that we're not going to be able to treat them if we don't treat them now. So that's going to be people who we don't have an address or phone number, or they don't, they're passing through. So we're presumptively treating, and we will get those results back for an RPR and those titers. There's a possibility of a that the rapid test was incorrect, in which case they did get some shots that they may not have needed. But we would rather err on the side of treating someone who does need it. As everyone knows, we're typically wanting to use bicillin. Doxy is being used in certain circumstances. I know there's some other options right now as well. And then depending on staging, which we will find out again after the rapid test, so there's still some stuff that has to happen, then they may require further treatment beyond just the one injection or perhaps the 2 weeks of Doxy. And that we will have to wait for those serology results. And then once those results come back, assuming they do have a reactive RPR and titers are elevated, then DIS will be notified and they're going to do their follow-up, staging, contact tracing, and confirming treatment. Next slide, please. All right, and then next steps for both HIV and hepatitis C. Both of these, we are not doing any kind of treatment after reactive results. So if we have one reactive point of care test, so for example, our OraQuick HIV comes back reactive, we are definitely going to do a blood draw to confirm that diagnosis. If we do have two reactive point of care tests, the rapid test, our case, the ChemBio and the OraQuick, that is enough for an HIV diagnosis. However, we still want to do a blood draw, get that sent off to the lab, get that confirmed, and also look at co-infections. So hepatitis C, syphilis, Hep B, ideally also looking at chlamydia, gonorrhea, possibly trich. And then we want to make sure to get them into primary care if they're not already, and some sort of HIV case management. Shout out to WinCap. That's who we send our people to. So it's really important that we provide a lot of education. Again, we are not telling someone they have HIV unless there are those two reactive tests, but we want to make sure to let them know, like, these tests are very accurate and we want to confirm them for you. And here's some steps in education, and make sure that they have the resources they need to follow up. And then for hepatitis C, if we do have a reactive result, once again, we want to do that confirmatory blood draw, both to confirm diagnosis and infection status. So there's both active or previous infection, and some of you may know that in about a third of hepatitis C cases, your body is actually able to fight that infection off on its own. So even if someone does come back reactive and they've never been treated, it's possible they don't actually need treatment. And then we do want to get them connected to primary care. They will need further testing if it is an active infection to determine what kind of next steps and treatment that they will need. And then hepatitis C bridge counselor, in our case, is someone who's managing the Hep C cases and can get them into care. And then just one last quick story as we wrap up. So we did find someone with a reactive HIV result, and this was someone who did not think they had HIV. They did not think they had been exposed. They weren't even looking for testing, but we showed up and we offered the testing, so they got it. Turned out that they had been exposed at some point, and we were able to get them into care with WinCap and get the resources that they needed really quickly. And that was, something that could have continued to spread and affect them negatively for an unknown period of time. So that's why we do what we do, because we want to catch it, and especially catch those, or find people who need those resources and aren't necessarily seeking it out. So I'm going to pass it over to Sue to wrap it up.
Yeah, thanks, team. Here's the team with a beautiful mountain setting. Don't go to our website. It's under construction. You can reach out to me. That's my email. But I just want to summarize by saying, if you're not doing rapid testing yet or don't have any kind of outreach, start trying to do it. We've got to get more of it out there. It's really important to normalize STI testing, STI prevention, and STI treatment. We want to destigmatize it. Whenever we're doing rapid testing, no matter what, it is going to spur action, regardless of the results. So if someone has, all negative HIV, Hep C, syphilis, you've at least, you've alleviated some anxiety. But it's also a good time to start talking to people about PrEP, about doxypap, thinking about their sexual health, linking them back to our harm reduction syringe service program. And then what I like to say to everyone before, people are oftentimes nervous. What I like to say is, look, even if every test came back positive today, let's say worst case scenario, we can do something about everything. We now have a cure for Hep C. We can link you to a bridge counselor, get you into treatment, and you can be cured of hepatitis C. We got our bicillin right here, or our doxy. We can treat syphilis. And as we know now, people are surviving and thriving with HIV. It is not the death sentence that it once was. So, information is powerful. And if you guys have any questions, want to reach out and see how you can get this going in your health department, we'd love to talk to you more about it. I did see there was a question. Yes, we do. We're public health. We're poor, so yes, we do the state rapid testing program, and that's how we get our tests. And so I'll just open it up to any other questions.
Thank you so much, Libby, and the whole of the Bunkum team. We're really excited with the information you presented. It definitely shows us a practical approach to addressing sexual health needs in the community, especially when there's a huge deal of stigma and there's a lack of resources. There is one outstanding question in here, and I don't know if your team extended the point of care testing project you just mentioned into the community for people who are pregnant. Was this a testing group that you all incorporated in your screening efforts for any of your rapid testing for HIV, syphilis, or anything like that?
Just to confirm, was the question, do we test people who are pregnant? Is that correct?
Yes.
Yes, we do. So we'll test anybody. We are not specifically we're not, going to, a OBGYN clinic, for example, but anybody who comes to us who is pregnant, we are happy to test them. We would love to test them and to find out. And in the very near future, we will also be doing pregnancy testing on our mobile unit. So it might be a time that someone could both find out that they're pregnant and maybe they have syphilis, and we can support them in both of those areas.
And at the same time, be like, have you had your DTaP, and are you in prenatal care? If not, how can we link you into prenatal care? So it's like, as we said, people have lots of things going on when we see them, and it's very rarely just the one thing. So
thank you. And you highlight the importance of health departments in providing wraparound services and being the safety net for the community for all of those things you mentioned. I was just making that comment in reference to the one that was there in the chat about thinking about using point of care testing for syphilis specifically in pregnancy to try to work to decrease congenital syphilis rates. And so that is a huge task that we now have on hand with limited resources and limited people power. So something to keep in mind, and you all seem to have a great thing going. So thank you for sharing. I know that Dr. Van Guren has vigorously been working in the chat to answer questions that have been in there. Are there any outstanding questions that we might consider bringing out loud? Dr. Van Guren, I know you've been typing things.
I tried to get most of them. If I didn't answer sufficiently, please feel free to reach out via email. I put my email in the chat as well. And there are a few questions about y'all's logistics in Bunkum if y'all want to look in the chat. Do y'all operate daily? There's several questions about that.
Do you have a schedule that you can share with the larger audience?
Well, normally we would say just go on our website. I'm going to be completely transparent. It's a mess. They just redid it soon. Check in soon on the website. But yes, our calendar says everywhere we go. And we typically, the minimum we do is 3 outreaches a week. We always say we can't do more, and sometimes we get talked into it. But it's a lot just to get everything coordinated, and you got places you get, you have your setup, you have your breakdown, we still, turning in our labs, all our charting, and just trying to get the logistics and everything done in the days that we're not out in the field.
I'm looking at a question here that says if you have a patient with a positive syphilis test through the mobile testing, how are the patient's syphilis stage without an exam? I will say, ideally, if we have a reactive result, like I said, we're going to draw a confirmatory lab. We also do want to get them into a provider. That is the goal. It's just not, it doesn't always happen depending on that patient's circumstance, but that 100%, that is, we're going to do everything we can to make sure that that person is able, ideally, to get into our health department for one of our providers to see and ask further questions. And then we also work very closely with DIS, who goes and tracks down whoever they can as well. And we will make sure to ask as many questions as possible. We do want them to have that physical exam when at all possible.
Yeah, we're always, we definitely offer, we schedule people, we do it, but some of what we're doing, it's harm reduction. So we are, ideally, yes, and we want them staged and we want them seen, but well, hey, we're at minimum stopping the spread from that person.
I also do want to say we're an extension of our health department, and so we frequently touch base with our providers in our clinic. So even though we're out in the community, we're not standalone. We're very much an extension of our clinic. So we use our providers, often, right, with questions or, hey, this person has this, we definitely, they're there to back us up and support us. So we work together.
Thank you. A follow-up question on that. Do you provide transportation services for clients to get to the health department or resources for it?
We sometimes, we'll have bus tickets with us sometimes. This is one of we are not allowed to do that. So the quick answer is unfortunately no. We do work with one of our community partners is our Buncombe Community Paramedic team, and they are able at times to transport people in like a real emergency or outstanding case. They can provide that, but we can offer bus tickets. When we're dealing with unhoused folks kind of concentrated in downtown Asheville, fortunately, our health department, we're right across from the bus station. We're kind of in the thick of it all in downtown. So it's oftentimes not a very far walk for people.
Have you thought about piloting a treatment in the field protocol in collaboration with some of the healthcare providers that you work with in Buncombe?
That'd be the dream. That would be the dream. And all those machines that Libby was like, oh yeah, can we get some of those machines? And I would love it. Yeah. And that would be the dream. The way we schedule, this provider's in, people are going to be in immunizations or STI or family planning. And I would love the other schedule to be, and this provider's out on the RV with the mobile team. I would love it if we could offer every single thing our clinic offers. That is the dream. We are not there.
We can still dream, maybe one day. I do see another question in the chat, and this might be most appropriate for Dr. Van Gerwen. It says it's asking about the performance of the syphilis test related to, I'll read it out. It says the confirmatory labs for TPPA may vary depending on the specific point of care test. In that case, can one have a false negative or vice versa? It's further up in the scroll.
Yeah, I'm a visual person, so I'm trying to read it.
Go up to 119.
Okay. Yeah, so the confirmatory test may vary depending on the specific test. In that case, can one have a false negative or vice versa? So you're saying if you do the confirmatory test and it's positive, that the point of care was falsely negative? Yeah, I'm sure that's possible. I mean, when you go from one test to another, that certainly, opens up the door that one was falsely negative and the other was falsely positive. So always a good idea to, if you get them in to do the confirmatory test, go back and do another treponemal test is probably what I would recommend to do, or an RPR, just get more information. But yeah, definitely proceed with caution.
I'd also
Right.
just, I was just to add that it is possible to have a reactive RPR for other reasons, and even the treponemal antibodies. So that's why we do want to use confirmatory tests, that it could be
Absolutely.
reactive and it's actually not because of syphilis.
1,000,000%. Completely agree.
And then there's also a question here about its use on college campuses. It just says point of care testing broadly. It doesn't specify the specific type of pathogen.
Yeah, I'm sure it's being used. I think, not specifically at UAB. I'm not sure. I don't do a lot of work with student health. If Nick Van Wagner's on the call, he would know. But we do have a student health clinic that does pretty robust sexual health testing in general. And I think in outreach settings, like if you're doing things at orientation, doing point of care testing is a good option. But at least our student sexual health clinic does kind of the full gamut of non-point of care stuff as well. But I think there's an opportunity to do outreach similar to the mobile testing, pop-ups, things like that, utilizing these technologies.
All right.
Rapid trichomonas for men, I see that question. I'm not aware of one until the VISB comes out. That may be available. And I don't know if the Cepheid, I think you can use the Cepheid on men, but I'm not sure.
I think that wraps up all the questions that are currently in our chat. Likely this will continue to evolve because I believe there's probably a little bit of delay due to volume. We will make sure that you get all those questions as in panel, should you be able to answer them offline. I saw that Dr. Mobley dropped into the chat the state rapid testing program information for us. And Buncombe team, when you do have availability about your hours, please share. We are so excited about the program that you have running, serving the North Carolina community, and we look forward to some more information. And thank you for your time today, speakers.
Thank you. Bye-bye.